Welcome, Anupama. We are really looking forward how to manage maternal collapse, because it should just remain an obstetrical collapse, not an obstetrician's collapse. So
Yes.
what to do and what not to do, this is very, very relevant topic. Thank you, Lakshmi ma'am, for involving me. And thank you, Surekha, for inviting me here. Over to you, Dr. Anupama.
Sorry.
Please unmute yourself, Dr. Anupama. We are not
Now,
able
is
to
it
hear you.
unmuted? Is it unmuted?
Yes, yes. Go ahead.
Oh, a very good evening, respected seniors and dear friends. The topic which has been given is very interesting, and it is of day-to-day utility. Like all healthcare workers, be it others also, must have a knowledge that this thing is possible. At the outset, first, I would like to thank Dr. Lakshmi ma'am and Dr. Surekha for giving me an opportunity to speak here. If we talk about maternal collapse, we all might have seen cases who have suddenly collapsed in front of us, like in labor room, be it in OT or maybe in the wards. So this is a condition which needs immediate recognition and immediate management. Maternal collapse is defined as an acute event involving cardiorespiratory systems or central nervous systems resulting in reduced or absent conscious level, and which could potentially lead to cardiac arrest and death. It can occur at any stage in pregnancy and up to 6 weeks after birth of the baby. Importantly, if maternal collapse, which is not as the result of cardiac arrest, is not treated effectively, maternal cardiac arrest can occur. So this is the importance of identifying maternal collapse. The incidence of maternal cardiac arrest is now rising because of escalating maternal morbidity and mortality rates. Maybe this is because of high-risk pregnancies which we are frequently encountering. Effective management of cardiac arrest in pregnancy requires timely initiation of resuscitative cesarean delivery when indicated. Understanding the history, indications, maternal physiology, and surgical principles of resuscitative cesarean delivery is essential for all clinicians who are caring for pregnant patients. Now, we all know these causes of maternal collapse. The 4 H's: hypovolemia, hypoxia, hyperkalemia, hyponatremia, hypothermia. And the 4 T's: thromboembolism, toxicity, tension pneumothorax, tamponade, and eclampsia and preeclampsia. So whenever a woman collapses suddenly, at times we do know what is occurring. Like if she's bleeding, it could be hypovolemia, or if she's a case of severe preeclampsia, it could be eclampsia and it could be intracranial hemorrhage. So at times we would be able to identify the causes. It also could be a cardiac event like myocardial infarction or due to thromboembolism. So these are the various important causes which we should keep in mind whenever we see a patient with maternal collapse. Early recognition and prompt treatment of the cause is essential so that we can save the mother. Now, resuscitative measures during maternal collapse and during cardiac arrest have evolved over centuries. Initially, the baby was removed from the womb for the purpose of burial. This further has evolved into an attempt to salvage the baby initially. Then came the attempt to salvage the mother, that is maternal rescue. During this evolution, performing resuscitative cesarean delivery was most effective if initiated within 4 minutes of maternal cardiac arrest. And this concept led to the term 4-minute rule. That is, you need to initiate this at 4 minutes and complete it by the 5th minute. Terminology resuscitative cesarean delivery is now preferred over perimortem cesarean delivery, emphasizing the goal of maternal resuscitation rather than fetal salvage. So this procedure is primarily used to assist maternal resuscitation rather than save the fetus. Delivery should ideally be achieved within the 5th minute of cardiac arrest because it then would maximize maternal survival and reduce the risk of long-term neurological impairment to the mother. So maternal collapse, initially, various resuscitative measures are taken, and it may amount to CPR or defibrillation, IV medications, airway management. The ABC of resuscitation is immediately initiated it is the same, the algorithm is the same as that for non-pregnant women, but there are certain changes in pregnant women which we need to see. Pregnant women are likely to become more hypoxic than non-pregnant because of higher oxygen demand, and the gravid uterus impairs venous return due to aortocoval compression. Therefore, the cardiac output is reduced by 60%. So in such cases, by emptying the uterus, by delivering the fetus, we can reduce compressive forces on the great vessel and increase the cardiac preload, and oxygen consumption thereby decreases. Lastly, emptying the uterus allows more effective maternal CPR and more rapid return to spontaneous circulation. If it also allows for internal chest compressions, we can put our hand inside through the abdomen up to the diaphragm and compress the posterior aspect of heart against the chest wall. It improves the cardiac output. It has been seen that if it is done before 20 weeks, it has no proven benefit, but beyond that, if abdominal delivery is expedited in a timely manner, maternal survival is between the range 17 to 59% and fetal survival 61 to 80%. One important concept which should be kept in mind is manual uterine displacement. This helps in reducing compression of inferior vena cava by the gravid uterus, and the technique is up, off, and over. So try to lift, as you can see in this picture, try to lift the uterus above the inferior vena cava and aorta and push it to one side. Women in a fully supine position, the uterus is manually displaced, and this also makes cardiac compressions easier and effective. So one person is displacing the uterus and the other person is giving cardiac compressions. In some cases, when you're not able to lift it, a left lateral tilt at an angle of 15 degrees would also suffice, and a solid wedge extending from shoulder to pelvis can also be helpful. As you can see, a 30-degree elevation would help in improving cardiac output. Then the question arises, where is this to be done? Now, because of the 4-minute rule, we cannot shift the patient here and there. So in the hospital, the procedure should be undertaken at the site of cardiac arrest, be it the ward, be it the ICU, or even the operating table. Minimal equipment is required in clinical areas where pregnant women are kept, and they should have a designated equipment box that contains protective wear and antiseptic solutions, but the two main components should be a scalpel and clamps. All this requires effective team planning, and so all should be made aware of the situation so that in emergency they can handle it. They can even have a simulated practice of this event. So whenever maternal cardiac arrest occurs, first thing is to lift the uterus above the aorta, that is manual left uterine displacement, and activate maternal cardiac arrest team. So you're not alone, you need to ask for help. First, decide whether it is traumatic or non-traumatic. Usually in our conditions, it is non-traumatic. Commence CPR, follow the standard life support algorithms. At times, we may need to defibrillate, and standard energy doses would be required. Secure airway, anticipate difficulty, because in a pregnant woman, because of edema, at times there's difficulty in intubation. So that should be anticipated, and a senior person should be called or should be kept in your team. Ventilate with 100% oxygen, start IV above diaphragm, use drugs and doses, treat reversible causes. So when you know the cause is reversible, like if it is an anesthetic agent or if it is hypovolemia, it should be immediately treated. But in cases of traumatic cardiac arrest, early intubation and ventilation before chest compressions is advised. Now you're doing it and you've done it for 4 minutes. Still, there's no return of spontaneous circulation. Then it is this time that when you need to consider for a resuscitative hysterotomy or a resuscitative cesarean section if the gestation is between or above 20 weeks. So initially resuscitation, just a repetition, look, listen, feel, airway, breathing, and circulation is to be established. Certain important points which are to be kept in mind for pregnant women. Advanced airway management is required and should be anticipated. Difficulties can be encountered, especially in third trimester pregnancies. There is a risk of gastric aspiration because of the pressure of the uterus on the stomach and laxity of cardiac sphincter. An experienced anesthetist should always be called for. So you've started cardiac chest compressions. You've done left uterine displacement, airway, oxygen, IV exercise started. You keep on doing it till the 3rd minute or 4th minute. When you see that there's no return of spontaneous circulation, then take a decision for resuscitative hysterotomy. Do not shift the patient, perform it at the site. Minimal equipments are required. The incision skin. So you can wear gloves and take a scalpel, clean the abdomen with betadine solution if it is available. The incision which is advised is a vertical incision. Give a vertical incision. Go up to the uterus, give a transverse incision on the uterus or even a vertical incision on the uterus and deliver the baby as fast as possible. Within 5 minutes, deliver the baby. Now, delivery of the baby causes release of blood from the uterus, which goes into the heart, and this improves your resuscitative efforts. So if it is successful, then shift the patient. If it is successful, there is return of circulation, shift the patient to an OT, and then there only you close the abdomen. But if it is not successful, continue CPR, allow time for CPR, and then in the meantime, you need to discuss with your team and decide when to stop resuscitative efforts. So this is the procedure. As you can see, a vertical incision is given, the baby is delivered and handed over. At times, when there's return to spontaneous circulation, there would be excessive bleeding, and you would need to give uterotonics. You need to clamp the cord, deliver the placenta, and immediately shift the patient to the operation theater. Aftercare, appropriate neonatal care and family support is very important, whatever be the outcome. Keeping contemporaneous medical notes can be difficult, but all staff should ensure that comprehensive notes are added to the medical or nursing records as soon as possible after the event. Entries should be signed, timed, and dated appropriately because these things can have lots of medico-legal implications, and that is why documentation is very important. Accurate documentation, a completed critical incident report are very important. Now, at the end, whatever be the result, whether the mother be saved or not, debrief and emotional support, not only to the family, but to the people, to the team who is involved in resuscitation efforts is very important. A distress caused by maternal cardiac arrest cannot be underestimated. For the family, unsuccessful resuscitation means loss of wife, daughter, mother, and possibly a much wanted baby. Even if resuscitation is successful for both the family and staff members involved, the emotional trauma from such a dramatic event can have significant emotional consequences. Both relatives and staff members should be offered a thorough debrief and a detailed exploration and discussion of the events. So all the events need to be discussed, why this thing was done and how it was done. And the reason for doing it all have to be discussed with the family as well as staff members. So advanced life support is required in certain situations. By advanced life support, I mean, besides ABC, that is airway, breathing, and circulation, at times, if the cardiac rhythm is shockable, we would need to use the defibrillator. So if there's ventricular fibrillation, ventricular tachycardia, then a defibrillator can help in improving the cardiac function. So the same thing, call for help, start CPR, do rhythm assessment. If it is shockable, ventricular fibrillation or pulseless VT, then in those cases, a defibrillator is applied. Now these defibrillator pads, they can, because of the enlarged breast, cannot be placed on the upper abdomen, on the upper chest. So one on side and one in the center can be placed, and that can be helpful in initiating the cardiac contraction. The various drugs which are used, epinephrine, amiodarone, epinephrine, and advanced airway would be required in all these such cases. So the take-home message is the key to achieving optimal maternal survival is the rapidity with which the resuscitative hysterotomy is done. That is the rapidity with which you take the decision to do it. Rapid and effective action can be improved through multidisciplinary team training. As with all critical obstetric emergencies, a detailed documentation is vital.